Good morning, everybody. So today, my topic of presentation is approach to dystonia syndromes and some common focal dystonias. So this dystonia is a difficult entity to diagnose. It is difficult to define. So the dystonia study group in 2013 had a paper which defined dystonia, including phenomenology and classification of dystonia. My talk today will be based on this classification. So coming to definition of dystonia. So dystonia is the third most common movement disorder, like after Parkinson's disease and essential tremor. Dystonia is the third most common movement disorder. And it is characterized by sustained or intermittent muscle contractions, causing abnormal, often repetitive movements, postures, or both. That is, or both, can be both movements and postures. And the dystonic movements are typically patterned, twisting, and may be tremulous. It's often initiated or worsened by voluntary action and is associated with overflow muscle activation. I'll be showing you videos of all these points. So most cases will have combinations of these abnormal movements and postures. There are some exceptions. Blepharospasm and laryngeal dystonia, they are not associated with postures, but they are characterized by focal involuntary contractions that interfere with physiological opening or closing of the eyelids or of the larynx. Right, so let's come to the dystonia phenomenology. And as discussed in the definition, the core clinical features of dystonia is dystonic postures or movements. And these are influenced by voluntary movements or voluntary maintained postures, as in anti-gravity support. So dystonic postures, they can affect body parts like the affected body part like neck, trunk, limb is flexed and twisted along its longitudinal axis. There is a sensation of tightness and traction in the affected part. That is dystonic postures. Dystonic movements may have a twisting nature or a pull in a preferred direction, that's including dystonic tremor. And the movements are repetitive and patterned. They are consistent and predictable. Unlike chorea is little of a semi-purposeful. So dystonic movements are repetitive and patterned. They are consistent and predictive. And movements are often sustained at peak severity and lessen at a given posture, like the null point, which may also be seen in dystonic tremor. So dystonic postures, dystonic movements are repetitive and patterned and can have a null point. So unlike the classic tremor, dystonic tremor movements are oscillatory, but they are not strictly rhythmic. They can be jerky and patterned. And dystonia and both dystonia and dystonic tremor, we also have a directional nature, and the movements can become worse in certain positions and improve in certain positions. This position in which it improves is called a null point. Now, apart from the movements and postures, another core phenomenology is this alleviating maneuvers. So it's also called sensory tricks or geste antagoniste. So they are voluntary actions that specifically correct the abnormal posture or alleviate the dystonic movements. They are usually simple movements involving or directed to the body region affected by the dystonia, but not forceful opposition to the dystonia. For example, patient with cervical dystonia, patients can touch either chin or the back of the head. So these simple movements give temporary relief of the dystonia. That's called sensory tricks or geste antagoniste. So alleviation of dystonia occurs during the gest movement, usually soon after the patient performs the maneuver. And it lasts for the duration of the gest or slowly wanes in effectiveness spontaneously before its end. And the gest is simple, natural and elegant, but never forceful. And the jest does not push or pull the affected body part, but simply touches it. Accompanies it during alleviation of dystonia. So apart from the geste antagonist, there are some other alleviating maneuvers, although they are not called as classical gests. For example, walking backwards can alleviate lower limb dystonia, and lying flat can alleviate truncal and cervical dystonia. So if you see this, see this phenomenon, then you can think of a dystonia. Another
walking forward.
Walking backwards. Suppose a patient has a lower limb dystonia, if he walks backwards, that dystonia will not be present. So it's an alleviating. So another core phenomenology of dystonia is mirror dystonia. Unilateral mirror dystonia is unilateral posture or movement that is same or similar to the character to a dystonic feature that can be elicited usually in the more severely affected side when the contralateral movements or actions are performed. Simplifying, for example, patient has writer's cramp. So if we make the patient write with the left hand and you see the affected hand and you can see this mirror movements. We'll come in detail to that. So how do we bring out this mirror movement? At least 3 different types of repetitive tasks are performed at slow and fast speeds in the non-affected limb. So if we should perform this task in the non-affected limb, then the affected limb, these movements occur. So in the upper limb, you can use sequential finger movements, piano playing movements, hand opening or closing, pronation, supination, writing. Writing is in writer's cramp, you have to make them write to bring out this. Lower limb, you can use heel stomping, toe tapping. So dystonic posturing in the contralateral limb occurs during the testing. So this is called mirror dystonia. So we'll come to a video which I'll play the video, you can listen to the video. They are describing the characteristic movements, postures, and the so you can see the posturing, movements, dystonic movements, postures. Many of the hand dystonias are task specific, like playing a musical instrument. So ancillary features, they are talking about sensory tricks. So he's touching, he has got an emotion dystonia and he's touching the lips, gets temporary relief and is able to play. So in the cervical dystonia, it's an external. So if somebody is touching if she touches it, so it's something. Musician dystonia is very common when they play the musical instruments. Their hands they have abnormal postures for task specific. And while eating, oromandibular dystonia worsens while eating. So he has a dystonia while lower limb dystonia is present while climbing stairs. So it disappears when walks backwards. So dystonia is null point is when some postures the dystonia becomes less. In that posture, the middle posture dystonia is not there. So we can see the mirror dystonia. So this is another video which shows the dystonic tremor. So that's a null point when some positions it does disappear. You can see some positions it's not there, null point. Right, so I hope that this phenomenology of dystonia is clear. So apart from this, so we saw the dystonic postures, dystonic movements, some gests. So another phenomenology of dystonia is overflow of movements. So there is unintentional muscle contraction which accompanies but distinct anatomically from the primary movement. It commonly occurs at the peak of dystonic movements. So again, once more, dystonic movements or dystonic postures extend beyond the commonly involved body region. So it's called overflow of dystonia. Well, again, we'll come to a video of that. So it's a video about limb to cranial overflow dystonia in a patient with stroke, post-stroke dystonia. So overflow of right hand dystonia to jaw opening. So the right hand, post-stroke dystonia, right hand. You can see the this overflow of dystonia into the face. Usually at the peak of the dystonic movement. So that I hope that that phenomenology of overflow is also clear. So these are the core features of dystonia: dystonic movement, dystonic postures. You can have even tremor, dystonic tremor also. There are certain alleviating features, just antagonistic, can have overflow. So dystonia is typically exacerbated by anxiety, stress, heightened emotions, and decreases with relaxation and is generally resolved during sleep. One slide on pathophysiology of dystonia. So dystonia is currently thought to be a brain network disorder involving several brain regions: basal ganglia, cerebellum, thalamus, and sensory motor cortex, resulting in abnormal neural motor programs. So as you saw in the videos, dystonia can be quite challenging to diagnose. So there are common misdiagnoses occur: PD, essential tremor, myoclonus, tics, scoliosis. They are all diagnostic challenges. The dystonia may resemble Parkinson's disease. Slowness of movement in the dystonic limb may be confused with a Parkinsonian bradykinesia. Increased tone from dystonia may mimic rigidity. And if dystonic tremor, if present at rest, may be misconstrued as a Parkinsonian tremor. So as you saw in the video of the dystonic tremor can be easily confused with essential tremor. So ET, as we know, presents with head, limb tremor, head, vocal cord tremor. Cervical dystonia, dystonic tremor can also occur in the same way. But dystonic tremor is not strictly rhythmic or oscillatory, is irregular, tend to involve the neck and less so in a limb, can improve with sensory tricks, particularly in cervical dystonia. So there are certain red flags. So if you see a patient with isolated head tremor, it's more likely the patient has a dystonic tremor than an essential tremor. If the head tremor is associated pain or asymmetric neck muscle hypertrophy, more likely to be a cervical dystonia. Vocal tremor with inability to change vocal pitch, again dystonia. Then lack of tremor improvement with typical ET treatment, again more likely for a dystonic tremor. Can be confused with myoclonus. Both have fast jerky movements, can mimic tremor, can be differentiated on an EMG. Tics, another differential is tic. And tics may also coexist with dystonia. So features of tics, as we say, tics classically have the premonitory urge prior to the movement, which is not seen in dystonia, and frequently associated with neuropsychiatric symptoms like ADHD, OCD. Right. So there are various dystonia mimics that we have to know. Blepharospasm, so you can have various conditions: ptosis, myotonia, functional dystonia, oromandibular dystonia, tetanus, hypoglossal nerve damage, cervical dystonia, various differentials are there. Congenital torticollis, cervical soft tissue, vestibulopathies, cranial nerve palsies, muscle weakness. Hand dystonia can have various differentials. Trigger finger, when this ulnar neuropathy at the wrist, when it doesn't have any sensory features, it can mimic dystonia. So these are the various mimics of dystonia. So coming to the clinical approach, so in this 2013 paper, they have classified dystonia into two distinct axes. Axis one is the clinical characteristic, that is age at onset, body distribution, temporal pattern, and associated clinical features. So axis one is the dystonia syndrome. Based on the features of age at onset, body distribution, temporal pattern, and associated clinical features, they have classified into various dystonia syndromes. The axis 2 is the etiology. That can be, is there any underlying nervous system pathology, or if it is inherited, acquired, or idiopathic. So we will come to the axis classification, the axis 1 and the axis 2. The axis 1 is the clinical characteristics. So it describes the phenomenology of dystonia in the given patient. And 5 descriptors are used to specify the clinical characteristic. And this axis classification is also used for prognostic purposes and for identifying management strategies. So these are the 5 parameters. So it can age at onset can be classified into infancy onset, childhood onset, adolescent onset, early adulthood, late adulthood. Based on body distribution can be classified into focal, segmental, multifocal, generalized, or hemidystonia. Based on temporal pattern, it can, based on the disease course, it can be static or progressive. Based on variability, it can be classified into persistent, action-specific, diurnal, paroxysmal. Based on associated features. So if the movement disorder is dystonia in isolation or dystonia plus tremor, then it's called isolated dystonia. There is no other movement disorder. And if you have combined, if the dystonia is combined with other movement disorders like Parkinsonism, ataxia, myoclonus, it's called combined dystonia. So age at onset, 1, 2, body distribution, temporal pattern, associated features, and also associated non-motor features. So coming to the age at onset, so clinically, the age at which dystonia starts is clinically important for both diagnostic testing and prognostic value. For example, if the dystonia is emerging during the first year of life, then it's very high probability of being due to an inherited metabolic disease. So if dystonia emerges between 2 and 6 years of age and in the background of some developmental delay, then it's more likely to be a dystonic cerebral palsy. And if the dystonia that begins in childhood is more likely to have a discoverable cause like a genetic cause, and it's more likely to progress from focal to generalized dystonia. Meanwhile, dystonias which emerge lately, that is after 50 years of age, focal dystonias, they don't usually generalize. Coming to body distribution, this is also important, also has implications for diagnosis and therapy. Example, considerations in adult onset focal dystonia are very different from those in young onset generalized dystonia. The treatment also differs. So treatment of choice for focal and segmental dystonias are botulinum toxin, while generalized dystonia, it's more like medications and surgery. So these are the regions that can be involved: upper or lower cranial regions, cervical region, larynx, trunk, upper limbs, lower limbs. These regions can be involved individually or in different combinations. And the distribution can change over time, and this can be progression to the previously uninvolved sites. So focal dystonia is only one body region is involved. Segmental is two or more contiguous body parts. So if the upper and lower face is involved, it's a segmental dystonia. Classically, it's Maid syndrome. Axial neck and trunk, segmental. Arm and trunk, leg and trunk. So they are segmental, more than 2 or more contiguous body parts. Multifocal is 2 or more non-contiguous body parts. For example, blepharospasm and writer's cramp, that will be a multifocal dystonia. Hemidystonia is one side of the body. And generalized is more than 3 parts. Trunk and more than 2 or more other sides is called generalized dystonia. So you can have the upper faces involved, you can have blepharospasm. The lower faces involved, you can have oromandibular dystonia. The neck is involved, you can have cervical dystonia. Upper limb, you can have hand dystonia. Trunk is involved, truncal dystonia. Leg is involved, you can have lower limb dystonia. Right. So that is age at onset. The body distribution. Next is the temporal pattern. So temporal pattern is also an important clinical characteristic which favors diagnosis and treatment. So disease course, dystonias can be either static or progressive. For example, a patient with a dystonic cerebral palsy, we know it's a static disorder. It's not a progressive disorder. While various genetic early onset genetic dystonias are progressive. They start focally and they progress to become generalized dystonias. And variability has different patterns. Persistent, when dystonia persists throughout the day. Most dystonias are persistent. And action specific. And that is when dystonia occurs only during a particular activity or a task. Like focal task. Writer's cramp is only during writing. Musician dystonia is only during playing musical instruments. And you can have fluctuations, diurnal fluctuations. Fluctuates during the day with recognizable circadian variations. So that's classical is dopa-responsive dystonia. It's an inherited disorder. It has fluctuations. And you can also have paroxysmal dystonias, sudden self-limiting episodes of dystonia, usually induced by a trigger with return to a pre-existing neurological state. So you can have various paroxysmal kinesogenic dyskinesias. So they can have paroxysmal dystonias. Right. So based on associated features, isolated or combined. So isolated dystonia is the only motor feature with the exception of tremor. And combined dystonia is dystonia which is combined with other movement disorders like myoclonus, Parkinsonism, ataxia, chorea. So in this case of combined dystonias, dystonia does not necessarily have to be the predominant movement disorder, and even may not be the prominent motor phenomenology. So you can have dystonia, combinations of dystonia and Parkinsonism in young onset Parkinson's disease. You can have this combination of dystonia and myoclonus. The next thing is the occurrence of other neurological or systemic manifestations. So these things can have give various clues to the etiology. So eye signs, ophthalmological signs, corneal abnormalities. If you see a KF ring, then you can suspect Wilson's disease. If you see supranuclear gaze pulses, you can think of other storage disorders on PSP. If dystonia is associated with cognitive impairment or epilepsy, you can think of gray matter disease. If dystonia is associated with spasticity, maybe the leukodystrophy. Dystonias can have element involvement, can have peripheral neuropathy, myopathy, can have systemic disorders, liver disorder, like dystonia with liver disorder can be Wilson. Dystonia with organomegaly can be a storage disease. Skin, connective tissue, skeletal involvement, can have hematological involvement, endocrine abnormalities. Right. So after this, after we go through this axis one, we have to make a dystonia syndrome. So imaging, what is the role of cerebral imaging, MRI? So it's not necessary in most adult onset focal dystonia. And however, but MRI should be considered in all early onset cases. In childhood and childhood onset dystonias, we should do an MRI. And all cases with combined dystonia with combined other movement disorder, definitely we should consider an MRI. Most of these common things like cervical dystonia, focal writer's cramp, blepharospasm may not require an MRI. So it should involve iron sensitive sequences. That's the SWI sequence. So based on the imaging abnormalities, we can help further characterize the dystonia syndrome. Can have basal ganglia abnormalities. They can be ignious signal, cystic degeneration, atrophy. There can be abnormal iron deposition like NBIA. There can be abnormal signal or atrophy of brain outside the basal ganglia. There can be white matter changes. Even it can be normal also. Presence of a normal MRI in the presence of a progressive dystonia. Again, so most of the primary dystonias, DYT1 all have a normal MRI. CT can be more sensitive in detecting basal ganglia calcifications. So blood investigations. So normal focal dystonias may not be of much help, but all these patients with combined dystonias, Blood counts, look for anemia, leukopenia, thrombocytopenia. Look for blood film to look for acanthocytes. Blood chemistry to identify liver, kidney disease, iron studies, manganese levels, calcium, parathormone, especially in patients with basal ganglia abnormalities. Uric acid can be high in Schneider. So another thing is Wilson's workup. Any patient presenting with dystonia, we should consider the possibility of Wilson's disease. So copper ceruloplasmin, slit lamp for KF ring in 24-hour urinary copper should be sent for. What is the role for neurophysiological investigations, nerve conduction studies, somatosensory evoked potentials? They can be used in progressive dystonias. Sensory examination may not be reliable. So to exclude a neuropathy, we can use nerve conduction studies, evoke potential to detect central sensory involvement, or sometimes even giant cortical potentials. We can use SSCPs. So after we do the clinical examination and can do the basic things, so we have to put together a dystonia syndrome. So what is a syndrome? So syndrome is a characteristic collection of symptoms and signs that tend to cluster together. Sometimes unique to a single disease, but more commonly has multiple potential etiologies. So what is the utility of making a dystonia syndrome? So identification of a syndrome limits the list of etiological differential diagnosis. So this is the next step after classifying the phenomenology in order to guide diagnostic investigations or management. So each syndrome in turn generates a list of potential etiologies that can guide specific diagnostic tests or management. So the mainly dystonias are classified into the isolated and combined. That's the main classification. So let's take this example. So isolated focal dystonia, patient develops an isolated focal dystonia in childhood versus an isolated focal dystonia in adulthood. So what is the isolated focal dystonia in childhood? Wide differential diagnosis, requires detailed investigation, genetic evaluation, because there is a high chance that this focal dystonia will progress to generalized dystonia and can also herald the onset of progressive neurological illnesses. So same situation, isolated focal dystonia in adulthood. So as we know that this adulthood focal dystonia is mostly sporadic, idiopathic. It does not progress to generalized dystonia and rarely heralds the onset of any progressive neurological disease. So dystonia syndrome, making a dystonia syndrome is very important. So let's see some of these syndromes. So the syndrome of early onset generalized isolated dystonia. So we may not be seeing this, so mostly pediatric neurology will be seeing it. So dystonia beginning in childhood often progresses to generalized involvement, sometimes quite rapidly. We frequently have a genetics cause like DYT1 torsin mutations, DYT6 THAP mutations. So that is the early onset generalized isolated dystonia. That's a syndrome. The common dystonia syndrome that we see is adult onset focal or segmental isolated dystonia, like your cervical dystonias, cranial dystonias, blepharospasm, oromandibular dystonia, task-specific dystonia. So this is the common dystonia syndrome that we see, usually idiopathic, and this is the most common dystonias. And they're infrequently generalized. They don't start in the like saying in adults. Patient don't develop cervical dystonia and becomes generalized. And these task-specific dystonias may progress to involve other tasks and can sometimes extend to contiguous body regions. Sometimes so neck can extend to the trunk. And they are generally persistent. So once it starts, it continues as a lifelong condition. Rarely spontaneous remissions can be there, but 68% eventually relapse. So this dystonia syndrome usually manifests in middle adulthood, typically in 4 decades, usually affect the arms. Classical example is writer's cramp. And dystonia manifesting a little bit later in the fifth decade usually is cervical or cranial dystonia. So we'll see the common focal dystonias. See, cervical dystonia is the most common form of adult onset dystonia, mostly idiopathic. Age at onset is between 30 to 70 years. Average age of onset is 41 years. Women are most affected than men. Rarely they can have genetic causes. Mostly it is idiopathic. Rarely some genetic causes can be there. And rarely some acquired causes like neuroleptic medication, trauma. Post-traumatic cervical dystonia is also described. So it's characterized by abnormal head and neck postures. Shoulder muscles can also be involved. So as we saw in the phenomenology, two other things, alleviating maneuvers, sensory tricks, commonly as we saw in the video, placing a finger on the chin or a hand in the occipital area of the head. Then there is pain or discomfort involved in the neck and shoulders. So it can be classified into various types: torticollis, anterocollis, laterocollis, retrocollis. So we'll see some videos of electron display. These are the various types of cervical dystonia. So some have this tremulous movement. Some have only the posture. So symptoms, so once it starts in the neck, symptoms spread can occur in fewer patients. So spread occurs in around 8.4% of patients, that too within the first 3.5 years from the onset. Most commonly spread is to the upper limbs. So cervical dystonia usually progresses in the first 5 to 10 years, reaches a plateau, after which it becomes a relatively stable, lifelong condition. Right. So next is blepharospasm. So adult onset focal dystonia characterized by stereotype bilateral synchronous orbicularis oculi spasms. Age similar 50 to 60 years, more prevalent in females. Primary, usually it is primary, but can be secondary to some neurodegenerative conditions like Parkinsonism, midbrain lesions, drug-induced. Usually insidious onset eye irritation or dryness, followed by excessive blinking, especially in bright light. We can see dystonic contractions of the orbicularis oculi. Some people have a sensory trick. Touching the face or forehead or eyelid helps to open. And differentials are eyelid tics, hemifacial spasms, facial chorea, praxia of lid opening, frequent blinking. Treatment is again botulinum toxin. So we'll see a video of that. So they do like try to Right. Next, we'll go to hemifacial spasm. It's not a classical dystonia in the sense. It's actually a peripheral myoclonus. So involuntary, irregular, tonic-clonic movements, muscles innervated by the lateral 7th cranial nerve. Age of onset is usually 40s and 60s, more prevalent in females. Primary hemifacial spasm results from vascular compression of the ipsilateral facial nerve. Secondary can be due to Bell's palsy, facial nerve injury, demyelinating lesions, mass lesions. So another important feature is the other Babinski sign. It is co-contraction of the internal part of the frontalis muscle causing elevation of the eyebrow with spasm of the orbicularis oculi. So I'll come to the video of that. Can have various mimickers, can be functional, focal tics, focal dystonia, facial myoclonus, hemimasticatory spasms. Treatment, we can try carbamazepine. If not responsive, we can go for botulinum toxin. So we'll see a video of it first. You can see the frontalis muscle. Very, very rarely it can be bilateral also, bilateral hemifacial spasm. This is some differential diagnosis of hemifacial spasms, synkinesias. So all that twitches in the face is not hemifacial. Hemimasticatory involves the trigeminal muscles, masseter. One more video, we can see the other Babinski sign. Look at the frontalis muscle. If we see the other Babinski sign, you can be confident it's a hemifacial spasm. Psychogenic and all that won't be there. Other Babinski won't be there. So coming to next focus, oromandibular dystonia, there is tonic or clonic movements, contractions in the lower facial muscles, including labial, lingual, masticatory, pharyngeal muscles, in isolation or combination. Starts in middle age, 50s, more prevalent in females. Primary is mostly idiopathic, secondary can be in tardive neurodegenerative conditions like neuroacanthocytosis, PCAN, focal brainstem lesions, hypoxic injury. So based on the, it can be classified into jaw closing oromandibular dystonia, jaw, this is the jaw closing, this is, and can be jaw opening oromandibular dystonia, jaw deviating oromandibular dystonia. And if it involves only the tongue, it's called lingual oromandibular dystonia and can be tongue protrusion, tongue retraction, tongue curling, tongue laterotrusion. So these are the types of oromandibular dystonia. Treatment, oral appliances, Then we can use medications, botulinum toxin. Or see video, we can see of a patient with. As a jaw closing. Lightus cramp more frequent in males as compared to the other dystonia. The age onset is earlier, fourth decade. Others you see cervical dystonia, blepharo, and all in the fifth decade. Lightus cramp occurs a little earlier. Symptoms usually insidious in onset, progression over months. Affected individuals usually present with progressive cramp, ache, stiffness of the fingers. In addition, forearm and arm can be involved. There can be various sensory tricks. And as we saw previously, you can have mirror dystonias. And these mirror dystonias can help to identify the dystonic muscle activity and to distinguish dystonia from the compensatory muscle activity. So based on the pattern, it can be a focal flexor pattern, wrist and finger flexor pattern, focal extensor pattern, wrist extensor pattern. So either the flexor compartment is involved, it can be flexor. The extensor compartment is involved, it can be extensor. We'll see a video. So as we see, it's an extensor type. Fingers are going into extensional while writing. He didn't have any mirror movement, so. So we saw this syndrome, dystonia syndrome. We saw the early onset generalized dystonia. Then we saw the adult onset focal segmental dystonias, common dystonias. And there are some certain dystonia syndromes which we see are which are red flags for the subsequent development of combined dystonia syndrome or risk factor for a neurodegenerative disorder. We'll come to some. So isolated cranial dystonia in young adults and children. So as we saw in this the videos, the blepharospasm or oromanular, they never occur in young adults or children. So they are always in the fifth decade. If you see a cranial dystonia in young adults or children, then it's a red flag. So that we have to understand. So oromandibular dystonia in young adults and children occur mostly in the setting of either a generalized dystonia. So distinctly unusual, should raise concern that it's an early manifestation of what will evolve into a combined dystonia syndrome or a neurodegenerative disorder. Classically, NBIs, all these various NBIs say they present with a young adult or childhood onset oromandibular dystonia. Very prominent OMDs, Leishman, glutaric aciduria, neuroacanthosis, or NBI. So adult onset isolated limb dystonia. So as we see, most of them are upper limb borne task specific dystonias. So isolated adult onset lower limb dystonia is very less common, and mostly it can be a static of a Parkinson's disease. If you see a patient with lower limb dystonia, adult onset lower limb dystonia, then it may evolve into a Parkinson's disease. Limb dystonias emerging in adults without task specificity or those that rapidly lose task specificity again should raise concern that they are the presenting sign of an underlying neurodegenerative disorder, especially Parkinson's disease or atypical Parkinsonian disorders such as a corticobasal syndrome. Truncal dystonia, isolated or prominent truncal dystonia at any age should raise suspicion of an acquired neurodegenerative disorders. Can be bending forward, backward, sideways. So opisthotonus, often combined with retrocollis, is a particularly common manifestation of tardive dyskinesia. So all these patients with tardive dystonias will have opisthotonus combined with retrocollis. If it is occurring in young children, maybe a part of generalized dystonia due to several inherited metabolic disorders such as Mishnahan, neurotransmitter disorders, storage disorders. So truncal dystonia should raise suspicion. Adult onset generalized dystonia, again uncommon, should always raise suspicion of underlying neurodegenerative or genetic cause rather than idiopathic. Hemidystonia occurring at any age, usually associated with a contralateral cerebral lesion, usually in the basic line. So these are the isolated dystonia symptoms, what we saw. Then the combined dystonias, dystonia with Parkinsonism, dystonia with spasticity, dystonia with ataxia, dystonia with myoclonus. So each will have a list of differential diagnoses. Dystonia with deafness, dystonia with ophthalmological abnormalities, dystonia with dementias. So as an example, I'll just cover dystonia Parkinsonism. Can be a dopa responsive dystonia due to Wilson disease, various genetic Parkinson's, due to various neurodegenerative disorders. So after we make the axis one, that is a clinical classification, next step is axis 2. So whether there is a pathology, there is neurodegeneration, there is a static lesion, and whether it is inherited or acquired, inherited, dominant, recessive, acquired, perinatal brain injury, drugs, toxins. If it is idiopathic, if it is sporadic, familial. Right. So that is the approach to a patient with a dystonia syndrome. Any questions I can do?
If you have an overflow,